Welcome to The Explainer. Today, we're diving deep into bisphosphonates. These drugs are absolutely fundamental in treating bone diseases, and we're going to cover everything you need to know to master them, both for your patients and for those tough Viva questions.
So let's start with this question because it's a fantastic story. How on earth did an industrial water softener become a blockbuster drug for bone disease? I mean, it sounds a little crazy, right? But the chemistry actually makes perfect sense. See, way back in the 1800s, these compounds were being used to stop industrial pipes from corroding. And why? Because they're amazing at preventing calcium buildup. It just took, about a century for scientists to have that light bulb moment and think, hey, if this stops calcium from building up in pipes, what could it do for bone?
Okay, so what are these things, chemically speaking? At their heart, bisphosphonates are basically copycats. They mimic a natural compound in our bodies called pyrophosphate. But, and this is the genius part, they have one crucial tweak. Where pyrophosphate has a POP structure, phosphorus, oxygen, phosphorus, bisphosphonates have a PCP backbone. Swapping that oxygen for a carbon might seem small, but it makes them incredibly tough, almost bulletproof to our body's enzymes, and that stability is the key to everything.
All right, here's what we've got on the agenda. We'll start with the basics, get into the two main classes and how they work, look at the specific drugs you'll see, cover the evidence, the risks, and finally, we'll wrap it all up with a classic Viva-style challenge to test what you've learned.
Okay, let's dive into our first section. We're going to lay the groundwork here. To really get a grip on how these drugs operate, we have to start with their fundamental chemical structure.
So, that PCP backbone we mentioned, that's the secret sauce. Think of it like a grappling hook that has an insane affinity for bone mineral, specifically hydroxyapatite. It just latches on and doesn't let go. Now, the molecule also has two side chains, R1 and R2. The R1 group, which is usually a hydroxyl group, is like a power-up for that grappling hook. It makes the bond even stronger. But the R2 side chain, that's where the magic happens. This little piece of the molecule is what determines everything else, how potent the drug is and exactly how it works.
All right, moving on. Now we get to probably the single most important concept for classifying these drugs. It all comes back to that R2 side chain. Whether or not it contains a nitrogen atom splits the entire class of drugs into two very different families, with two very different mechanisms. You're definitely going to want to lock this in, because this distinction is a favorite for exams.
Okay, so check this out. The two classes work in completely different ways. On the left, you have the older, non-nitrogen bisphosphonates. You can think of these as a cellular poison. The osteoclast, the cell that breaks down bone, eats it up. But inside, the drug gets turned into a toxic, fake version of ATP, the cell's energy source. It basically gums up the works and kills the cell. Now on the right, you've got the newer, nitrogen-containing drugs. These are much more sophisticated. They're not a poison, they're saboteurs. They sneak in and shut down a specific enzyme called FPPS. This enzyme is crucial for making the little proteins that let the osteoclast attach to the bone. So, no enzyme, no attachment, no bone breakdown. It's precision versus brute force.
And here's the bottom line. That difference in mechanism translates directly to a massive difference in potency. That targeted sabotage is just way more effective. It's why the nitrogen-containing bisphosphonates are so much more powerful and are pretty much the only ones we use today.
Okay, let's move on to the actual arsenal of drugs. Now that we understand the how, let's look at the what, the specific bisphosphonates you'll see in practice and how they stack up. You can really think of these drugs in terms of generations. The first-gen guys, like itidronate, are the old-school, non-nitrogen ones. You don't see them much anymore. Then came the second generation. This is where you find the big names, like alendronate and risodronate. They added nitrogen and really became the workhorses for osteoporosis. And then you have the third generation, like zoldronate, which are the most potent ones we have, often given intravenously for more severe cases.
And this chart really drives the point home. Look at the data for vertebral fracture risk reduction. Alendronate, a second-gen drug, gives you about a 50% reduction, which is great. Risodronate, around 40%. But then look at zoledronic acid, a third-gen IV drug. It pushes that risk reduction all the way up to an incredible 70%. The evidence is pretty clear.
All right, so we know the players and we've seen the evidence. Let's get into the practical playbook. When exactly should we be reaching for these drugs in our clinical practice?
So, here are the main FDA-approved indications. Obviously, osteoporosis is the big one, whether it's postmenopausal, in men, or caused by glucocorticoids. But don't forget about the others. They're also key for managing Paget's disease of the bone.
and they're absolutely essential in oncology, both for treating hypercalcemia of malignancy and for helping patients with painful bone metastases. Okay, this next part is so important, especially for your Viva. How a patient takes their oral bisphosphonate is non-negotiable. You have to nail this counseling. First, the bioavailability is terrible, like less than 1%. If they take it with anything other than plain water, coffee, juice, even a crumb of food, absorption drops to practically zero. But even more importantly, it's about safety. If the pill hangs up in the esophagus, it can cause severe esophagitis and ulcers. So the rules are simple but strict. First thing in the morning, totally empty stomach, a big glass of plain water, and they have to stay sitting up or standing for at least 30 minutes. No exceptions.
Okay, on to our next section, risks and guidelines. You can't just know what a drug does, you have to know what it can do, both good and bad. This is where you really show your clinical expertise.
So when we talk about side effects, you can kind of put them into buckets. The most common stuff you'll see is GI upset, reflux, esophagitis, which is why that administration counseling is so key. For the IV drugs, you can see an acute phase reaction after the first dose, fever, aches, flu-like symptoms. But then there are the rare but really serious ones that you absolutely have to have on your radar: osteonecrosis of the jaw, or ONJ, and atypical femur fractures, AFF.
You need to know this definition cold. To diagnose ONJ, it's a 3-part test, and all 3 parts have to be true. First, the patient is taking a bisphosphonate. Second, they have exposed bone in their jaw that just won't heal. It's been there for more than 8 weeks. And third, they've never had radiation therapy to their jaw. That's it. It's a perfect Viva question.
The other big scary one is the atypical femur fracture. Now, the risk for this really climbs with how long someone's been on the drug, usually after 5 years or so. And here's the clinical pearl you need to remember. The patient often doesn't present with a sudden snap. They come in with this prodromal pain, a dull, aching pain in their thigh or groin that's been bugging them for weeks. If you hear that story from someone on long-term bisphosphonates, your alarm bells should be ringing. You've got to think AFF.
So this naturally leads to the idea of a drug holiday. Because the risk of things like AFF goes up over time, this is not a set-it-and-forget-it kind of drug. The guidelines suggest that after about 5 years on an oral drug or 3 years on an IV one, you need to stop and reassess. Is their fracture risk still high? If not, you might consider pausing the treatment. The great thing is, because these drugs stick around in the bone for so long, the protective effect continues even after you stop taking them. It's all about minimizing that long-term risk.
Okay, final section. Let's put it all together. Time for a classic Viva challenge to see if you can connect all the dots we've laid out.
All right, here's the scenario. A 72-year-old woman has been on oral alendronate for 8 years. She now presents with a new, dull, aching pain in her groin for the past month. So what is a top differential diagnosis? Take a second and think about it.
So how do you break this down? You just have to connect the clues. Clue number 1, the drug is alendronate, a bisphosphonate. Clue number 2, the duration is 8 years. That's definitely in long-term use. And clue number 3, the symptom is that dull, aching groin pain, that classic prodromal symptom we just talked about.
So what's the top concern? It's got to be an impending atypical femoral fracture. This is a textbook presentation, and your next step is crucial. You don't just tell her to take it easy. You order a plain X-ray of the femur right away. This is exactly the kind of clinical reasoning that shows you've mastered the topic.
And really, that little scenario brings us to the big takeaway for this whole topic. Long-term bisphosphonate therapy is all about constant reevaluation. You always have to be asking that question. At this moment, for this patient, does the benefit of preventing a common fracture still outweigh the small but serious risk of a rare one? It's a moving target, and managing it well is the art of medicine.